Good morning, good afternoon, ladies and gentlemen. Good afternoon, colleagues. We want to welcome you to the Health and Human Resources discussion debate this afternoon. My name is Zola Dantile from South Africa. I am chairing the session with this afternoon with my colleagues. I'd like to introduce also the members of the panel before we get into business. We have got here Dr. Saleh Oraibi from Jordan. There he's nodding. He has got PhD in physiotherapy and rehabilitation. So he's going to be one of the panelists. The next one is Dr. Michel Landry from Canada. He's assistant professor at the Department of Physical Therapy at the University of Toronto. All right. They've all got very long CVs, so I have requested them to indulge in shortening them up. They have agreed. And I've also got Dr. Amparo Mogallon from Colombia. And she's a physiotherapist and a professor at the School of Medicine and Health Sciences at the Rosario University in Colombia. And I've actually also got Barbara Rang from Switzerland. She is currently the project manager for the International Committee of the Red Cross and the scientific collaborator at the University of Applied Sciences of Western Switzerland. She's a physiotherapist. And I've also got, lastly, the panel member, Kanchan Sangroula from Nepal. She's a physiotherapist working at the Nepal Orthopedic Hospital, and she was the ex-president of Nepal Physiotherapy Society. And maybe also to say about myself that I'm the outgoing president of the World Confederation for Physical Therapy, WCPT. I've retired after 12 years in the executive. Is that not wonderful? Take early retirement. Talking about health human resources this afternoon, I'm just going to give an overview, and then I will sit down, and then the members of the panel will actually give us some other insights, and we can then begin to debate issues from the floor and from the table as well. When we look at the demand for physical therapy, one of the things that drives the demand for physical therapy worldwide is because life expectancy has increased in developing countries, as well as the rise in chronic lifestyles, both in developed and developing countries, and that has driven the rise for the demand in physical therapy. Now, there is a global shortfall of physiotherapists, as well as health professionals that are trained worldwide, the health workers generally, to be able to meet such a demand. In the developing countries, when we talk about health workers, I'll specify. Health workers include nurses, doctors, pharmacists, including physiotherapists. I'll specify when I talk about physiotherapists. In the developing countries have fewer than one health worker per 1,000 of a population, against the developed countries that have 10 health workers per 1,000 members of the population. If you want to find more information about that, you can read the WHO World Health Report of 2006. Right. Now, if we talk now specifically about the number of physical therapists, WCPT, as of this slide was done before the general meeting that took place over the weekend. There were 101 members, but to date there are 106 countries, and there's an estimate of about 350,000 physiotherapists worldwide. But remember, this figure that I'm giving you is only the statistics of WCPT. And there are other countries that are not members of WCPT, so their statistics is not represented in these numbers. So you can actually, therefore, appreciate the difficulty that we have in knowing exactly the shortage of physiotherapists worldwide. And also when the World Health Organization started this new dictionary, the Avicenna dictionaries, when they were expanding it from nurses and doctors, they only expanded it to other health professionals, the pharmacists and public health schools. So to be able to get accurate data on the global shortage of physiotherapy is a challenge as I'm speaking to you. So that slide is just to show the global health population. The panel members will actually pick up some of these points as we continue to debate, and we'll go backwards and forwards on the information on the slides. We look at the areas with absolute poverty. We look at the density of physiotherapists globally. And if you look at this, you can actually understand the need. If you look at the areas that don't have any color shadow, that is when there is no data that is available to be able to be analyzed. If you look at areas of high density in black, it's a very little patch in Europe where there's a density of physiotherapists. Just to give an example, I must apologize up front if I actually am saying incorrect figures of countries like Germany, who have got 45,000 physiotherapists compared to the country where I come from, where we have got 5,000 physiotherapists for a population of 49 million in South Africa. So we actually then understand the global shortage. And this one indicates the numbers of physiotherapists per population. We will not dwell on that one. Education and training. Where are physiotherapists trained? Who trains them? We learned during the Congress that some physiotherapy training programs, they are trained by the doctors, for example. We had a gentleman from Japan in one of the discussion sessions. He was saying that he even thinks that the exams that are written by the physiotherapists is actually exams that are set by the doctors, because they still need a referral from the doctor and a prescription to be able to treat. And I think it is a similar situation in some other parts of the US and many more other parts globally. Then Nepal, Kanchan will talk to Nepal shortly. And for example, also about education. In Bangladesh, it has 6 institutions offering PT training, and 300 have graduated. We use the stats from 2007. So if there is a shortage of, the output of physiotherapists for such countries is so low, will we ever be able to meet the need? And according to WHO, the training output for Africa range between 10 to 30% of the required output of physiotherapists and even health workers that are required to be able to meet the health needs and the demands of the populations. The programs that currently are given by our own institutions that are training physiotherapists worldwide, are the curriculum, is it relevant to the specific country needs, to the demands? You'll actually still find that what happens in most curriculum is that they include new information, but they don't take out the old information. And the curriculums end up being too cluttered, and they don't cater for the current needs. WHO is suggesting that in order to meet the needs of health workers, there should be training of mid-level workers to meet the demands. Institutions, governments, countries are in huge debate about how to go about the training of the mid-level workers. In South Africa, for example, we have got a problem of mid-level workers. They want to train a combined person, where this person will be trained quarter in occupational therapy, a quarter of physiotherapy, a quarter of speech therapy, a quarter of being a community rehabilitation worker. The trouble is the registration. Where are they going to be registered? Which board are they going to be registered under? Because all these professions have got their own different boards for regulation purposes. So they end up not being trained. Now, WHO is talking about task shifting to say that don't stress yourself. If you need mid-level workers to do health promotion, train them in health promotion. They take one task out of our many tasks that we are performing, and they actually be good in that. And the government and the countries and associations are grappling with those issues to in order to meet the demand. That's where this comes from. That is the training of the mid-level workers the solution in order to meet the demands. Physiotherapy services that are currently available, are they accessible to all members of the population, whether they're in urban areas or they are in rural, remote countryside areas? How is that compared in developing countries to developed countries? I do know that transportation becomes a problem in the rural areas and the countryside areas, that it becomes difficult to access the big institutions because physiotherapists tend to be located in urban hospitals and teaching hospitals rather than the clinics or the community healthcare centers or the small hospitals that are located in the rural areas. The populations, is it easier for children to access physiotherapy services or the elderly population? Which one is better? We don't know. We will talk about that during the debate. The location of services. Are our services located in areas that are accessible along the bus routes, along the train routes, along the tram routes, or accessible in order to get the cost of services? Our services for physiotherapy, are they affordable? Can people pay who can't afford, or those who can afford, are they affordable? Are there any cultural sensitive issues that we need to take into consideration? Security issues. In South Africa, before I left, there was going to be a march, a protest march, because one of their doctors was stabbed by a patient in hospital during consultation. Therefore, there is huge security issues around that. You actually find sometimes the health workers, when they take samples to the lab, the young female health workers, they get raped. Others, they get shot. So the practice environments are not secured. So that's one of the maybe issues that we need to talk about as we continue to discuss. The health employment policies, are they other issues that are affecting access to our services? The remuneration practices in the public versus the private sector, we need to consider that. There's some talk that says that private physios who work in private sector are better paid compared to the physios who work in public sector or for government. The issue there being the fact that they do not get, the ones who work for public sector in certain countries, they've got much more stability in terms of job security. They would have pension and they would actually have a guaranteed job as opposed to the private sector. Now, one of the issues that happened in Zimbabwe is that during the economic crackdown in 2008, they actually slashed the other zeros. You know, when you would actually have 10 billion rand in your bank account, then they slashed down the zeros, so you ended with 10,000 rand in your bank account. So the money shrinked as it was put in the bank account. So they no longer have pension. Now the question is, because they were working and they put pension aside, is that still the case? What happens in economic climates like we have in Greece? What lessons are there to be learned in health employment? Because they would always cut health service when there is a shortage in government. We have learned throughout the world. The employment priority and uneven distribution of health workers. We actually have heard that because of the employment issues, they would always want to employ people who have got language preference as opposed to people who are foreigners who would like to work in other parts of the world. Staff retention, what issues in employment policies, what is attractive for people to stay in their jobs is one of the considerations we want to put this afternoon. Staff migration from public to private sector, from rural to urban, one of the models South Africa adopted in order to address the issue of staff retention. They have a package that when you work in the rural area, you actually get a scarce skills allowance, which is much more an allowance that you get over and above your pay to somebody who works in the urban areas. The increasing movement of professionals globally, that if my husband were to decide to come and work in Switzerland, would I be able to work in Switzerland? Because there are these multinational companies that are located globally. So if they decide that for a period of time he needs to come and work, will I be able to come with him and get a job? Because I don't speak none of the local languages, will I actually be able to use my skill? Those are the issues that we need to consider with the increasing diversity of patient populations. We never thought that there could be migration of populations from one country to the other because of wars and tsunami disasters, as we are seeing today. One of the other issues is the awareness of physical therapy by the doctors who are at the referral point of patients, by the government themselves, that the policymakers don't understand the importance of physiotherapy. We had a case in Namibia where physiotherapy was classified as a rehabilitation professional. As a result, it was classified together with the roadworks, because you know when you do road rehabilitation, so physiotherapy was also classified together with that. So we actually had to talk to the Namibian government, do advocacy, and ensure that physiotherapy can be classified again with health. And those are the peculiarities that we find throughout. And lack of awareness about the services that physiotherapy renders among patients and amongst other health professionals as well. And about the patients themselves. I was going through the posters and talking to the people who were presenting posters, saying that we find that if a patient has been referred for physio by a physician, they don't come because they don't understand the benefit of physiotherapy. If they've got tablets on their hand, off they go home. They don't think it's important to still go for physiotherapy because they don't know the benefits thereof. What are the global initiatives that have been put in place in order to address some of the global issues that are affecting health professionals? The ethical recruitment of health workers. What we experienced in the past 10 years was that there would be adverts in every journal from the developing country to the developed countries to recruit workers. But government to government, they spoke and they had bilateral agreements, trilateral agreements, that they are not going to recruit health workers from the developing countries to the developed countries. There had to be an ethical recruitment so that they don't don't do brain drain from developing countries to developed countries. And there was also this multilateral code of practice, is what I've just spoken about, that the Commonwealth Code of Conduct, and how do they conduct themselves in recruiting the workers. The bilateral agreements to facilitate the return of migration that we have not experienced in certain countries, that there has been the migration of the return of the migrants. We are still finding them out there because the conditions of work back at home, they are still not as conducive as they should be. The migration for development of Africa initiative, what actually the governments have done in Sub-Sahara, they are saying that good, you can actually train in my institution, but after graduating, you go back and serve at home. They don't employ them anymore. Whereas before, you would actually have somebody from Kenya, for example, going down to South Africa to study, and on graduating, they would actually then be absorbed in the employment, in the workforce of South Africa. Because of this development in Africa initiative, they no longer allow, South Africa is no longer allowed to train them. Even if you were to go to Kenya or to any other country, you may not be employed there. You must go back to your country and practice in your country. So that's part of the global initiatives that have been put in place to control the health workforce. What are the myths and realities that we want to talk about this afternoon? The changing role of physiotherapy, has it enabled the population to have greater access of physiotherapy? We hear about the expanded scope of practice. Has that enabled access to physiotherapy? We hear about the entry level of physiotherapy that is no longer a BSc degree, is now at a doctoral level. Has that increased access for physiotherapy services? Physiotherapy assistants, are they a threat to the profession, the mid-level workers? In some countries they are, in some countries they are not. There's also another myth and reality that developed countries have no shortage of physiotherapists. We don't know. We want to hear from you whether developed countries don't have any shortage of physiotherapists, because there's a myth that it's only developing countries that have got a shortage of physiotherapists. I want to thank you for your attention and pause right here as my colleagues are going to be giving input. Thank you.
Good afternoon, everyone. My name is Mike Landry. I was introduced as an assistant professor at the University of Toronto, which is true for the next few days, and then I'm actually going to be moving to the United States to become the chair of the PT program at Duke University. So I look forward to working with the American PT Association. I'm going to go back a little bit and describe some of the slides from before. What you have here, and this is essentially to provide a little bit of context to the notions of supply and demand and to where shortages might fit. What you have here, there's a really wonderful research group based out of the United Kingdom. And if you just Google World Mapper, you'll get to a very interesting website where they have essentially looked at a whole series of variables and have a very interesting technique to present the data. So what you have here is sort of a graph of the world, but it is obviously skewed. And the skewed naturedness is because they have taken global population and they've correlated it with size of a country. So as you can see, up here, Canada represents just this tiny little sliver because we have 32 million people in the entire country. It's the second largest land mass area within a country, but our population is so small, and that is why this is represented by just a fine sliver. Whereas you have China and India, who obviously are overrepresented because they have such huge populations. So keep this in mind as we go through the next few slides. The next slide uses absolute poverty as the variable and has adjusted the borders of countries based on where absolute poverty in the world exists. Absolute poverty tends to be defined as where people live on less than $2 per day. So you can kind of see where we're going with this conversation maybe. Again, Canada fares out fairly well. Where we're sitting at the moment fares out pretty well, but other countries are not so lucky. Now, if we were to put a slide, well, actually this research group has used data that looks at physician density, so essentially where in the world do physicians work? And it is almost the inverse of what you'll see here. So the majority of physicians in the world are located in wealthy countries, OECD countries. So Canada is overrepresented, America is overrepresented, most of Europe is overrepresented. So this tells us a little bit about where the demand for health services are and rehabilitation and where people are located. We've taken a go at this kind of data. It's a manuscript that's in preparation. But as Zola was mentioning, when a country appears in white, it's because we don't have information. We don't have the data. This is a density map. So it looks at countries and calculates the number of physical therapists per 10,000. It becomes a health human resource ratio. And we tried to present this data in a whole series of fashions. In other words, have a color for those who have 5 PTs per 10,000 and more and use it as a gradient. But the gradient doesn't work because there are only about 10 or 12 countries in the world where you have numbers such as 5 or 7 PTs per 10,000. Most of the world finds itself in something like 0.02 PTs per 10,000. Zola gave a few examples before, and we could go on to others. And it's not just PT. When we began working in Ethiopia, there were 2 psychiatrists for the entire population. So what we're trying to describe here is that some countries have high density, which is represented by a very dark bar. You can't see it very well on your slide, but it includes some European countries. Most find themselves in moderate density. Moderate density was defined as between 2 and 5 PTs per 10,000. High density was 7 and more. Low density was, I think we looked at it as 0.5 PTs to 2. So you can see where the densities are fairly low, and we can guess that where we have scant data or no data, that these countries would end up being low or extremely low in human resource density. Now, that's not to say when you have more PTs in a population, you get good health, or that was always been a question. So in another study that we did, it's actually submitted, and I won't go through the methodology unless you're particularly interested, but I just want to highlight that there is a relationship between disability, prevalence, incidence in a country, and human resource density as it relates to physical therapy. So on the Y, this axis here, you have years of lost life per 10,000 population. Okay? Now, this is a gross measure of disability in an area. And along the X-axis, you have the density of physiotherapists and physicians. I'll explain why that is in a minute, but density of PT and physicians per 10,000. The data looks something like this. When countries have high years of lost life, they tend to have very low densities of PTs and physician groups. As you move along the curve towards your right, you'll find in Finland, which has some of the lowest years of lost life, also have some of the highest densities of physical therapists and physicians. The United States, UK, Canada, Oman, these countries the wealthier countries tend to find themselves on this axis, or in this situation, or this part of the relationship. So these are statistically significant data to show that there is a relationship of some sort. We can't quite understand it yet, but there is a relationship between the density of health providers and disability. We could not get to the point of having only PT because the data sets, the international data sets, are not good enough. So, one of my other points I'll make in a moment, but I'll say it now. WCPT has the moral responsibility to begin the process to figuring out where are PTs located, through whatever means that's going to be, through a common data set process, which has been ongoing now. But we are at a point where if we do not try to understand where we exist in the world and how we relate to public health indicators, I think we're going to find ourselves in a very weak political position to start arguing for anything such as Zola was saying about policies or education. Because right now, if we were to say, well, I think there was a slide that says Bangladesh has 6 training programs. Canada has 13. America has 216 or something of that nature, and growing almost every weekend. The question becomes, what is the right number? Where is the fine balance between supply and demand? Where is the demand? Where is the supply? And what we would say, where's the sweet spot? What is the right number? Is the right number a density of 5 PTs per 10,000? Or maybe the right number is 12. We, unfortunately, have no idea what the right number is. And we must collectively start changing that through data collection and through the beginning of analyzing some of this data to even have a global map, to even have an understanding. Now, I'll just make one other point, and then I wanted to clarify some of the slides before we move on to our next presenters. But I wanted to make the point that a PT is not a PT is not a PT. Now, that's a play on words, obviously. But what I'm trying to suggest is that even once we determine what the numbers are, what the ideal health-human resource ratios might be, we have to still drill down, because if I'm a PT who works in cardiopulmonary, I may not be able to be as effective and specialized in neurology as would be required. So just because we have gross numbers of people living in certain PTs in certain countries, it doesn't mean it's meeting the demand of that particular country. We need to understand what is the changing dynamics, the demographic transition across all countries, so that we can determine what kind of training programs are required for the whatever number of PTs is the precise vision. So with that, I'm going to say thank you. I'm going to pass the floor over to Zola, who will then call upon the rest of our colleagues to make commentary. We designed this to be somewhat of a debate discussion, but what we really want to do is try to understand your perspectives, because really the data is scant. We're not really sure where we're going as a global community, so we need to start moving the yardsticks, trying to understand. The American PT Association and the Canadian PT Association are hosting an international summit in 2012, and I have some pamphlets up front, and I'll leave them there, and you can look up our individual websites. But this is happening next year, specifically looking at health, human resources, and education. So I'd encourage you to get angry, get some good opinions, because that's what we're here for. Zola, you're next.
Right. Thank you to Mike. Any clap for Mike? All right. Because the slides are a joint product of all of us, so don't be surprised now and again. The panel members will take liberty to go to the slides and actually refer much more to the slides. All right. We're going to ask Kanchan from Nepal. Yes.
Hello everyone. Yeah, thank you. I'm from Nepal. And you have just seen the slide for global diversity of PT. And I think we are from country where we have 0.2% of PT for our population. We have 345 physiotherapists in our country for 30 million of population. We have 16 million population living in rural areas, 14 million of population living in urban areas. And we have 90% of PT work in urban areas. And in 10 years, we have 3 Bachelor of Physiotherapy posts which have been created under Ministry of Health in government hospitals. And we have 12 physiotherapy assistant posts in government hospitals. And in context of Nepal, physiotherapy assistant, they have qualified as diploma in physiotherapy, and they work independently. And remaining 342 PTs in our country work in private hospitals, INGOs, private clinics, or some of them are still unemployed. And out of 345, we had 200 as registered in Nepal Physiotherapy Association as members. We have 1 school of physiotherapy, so we have a big challenge that where are these new physiotherapists, new grads going to go and work? And another big issue is the migration of physiotherapists from our country to developed countries. Along with skilled manpower migrating, we have general population migrating to developed countries, leaving older behind, which makes need for healthcare even more. And retention is another problem. Even if we have physiotherapy posts available in rural areas, we don't have physiotherapists or any other health professional going there and working for a long time. It's due to various reasons like geographic condition of Nepal, geographic areas. We vary from land to high altitude mountains, so they don't like to go and stay over there. And also the facilities in the available facilities in rural areas like education and food, sanitation, all of these things. And accessibility is another big problem. We have very few physiotherapists for our country, and the knowledge about the physiotherapists among the doctors, government, policymakers, general population is very low. And we tried to do a survey from our physiotherapy association to find out the staffing guidelines, to lobby government for creating more physiotherapy posts in government hospitals. But according to Mike, I think you have also know that we don't have proper guidelines, and I think WCPT should play a big role. We try when we send an emails to many our friends in developed countries, and we got an answer that even the most developed country in the world didn't have staffing guidelines for physiotherapists, like number of physiotherapists in which according to the bed and the hospital. So I think it's one of the biggest issue that we should work, and I think it will help this smaller country to lobby government. And we have a big problem for transportation because I already said we have a plane to high mountain, so there are very few roads, and it becomes very expensive for the general people to take the service. As in developing countries, their income is just less than $1.5 per day, and we don't have any health insurance facilities, so it is one of the biggest hurdle. Thank you all.
Right, we actually have got representation from people around the globe. So, and we will actually then ask Barbara from the Red Cross.
Yes, good afternoon, ladies and gentlemen. I have the pleasure and the honor to represent the International Committee of the Red Cross. So the ICRC is an impartial, neutral, and independent organization whose exclusively humanitarian mission is to protect the lives and the dignity of victims of armed conflict and other situations of violence, and to provide them with assistance. The ICRC physical rehabilitation services support orthoprosthetic and physiotherapy activities in hospital and rehabilitation centers in countries where rehabilitation needs exceed the capacity of local health providers. In 2010, the ICRC supported 84 physical rehabilitation projects in 25 countries and 1 territory, such as Afghanistan, Sudan, or Georgia. It provided physiotherapy service to approximately 200,000 beneficiaries. Currently, the ICRC is working worldwide with some 160 national physiotherapists and 90 physiotherapy assistants or aides. 30 countries I mentioned before don't belong to WCPT today. Local physiotherapy professionals face considerable challenges, such as large number of patients needing rehabilitation, limited availability of physiotherapy services, few and poor training facilities, restricted access to continuing education, lack of professional recognition by national authorities, other professionals, or the wider public. Therefore, the ICRC proposes the following strategy to improve the sustainability of physical rehabilitation. Improve the functioning of existing physiotherapy services, if they are, in collaboration with other health professionals. Support the setup of appropriate physiotherapy services. Develop national capacity through training. Promote close collaboration with existing physiotherapy schools, for example, in developing continuing education programs. Provide support to physiotherapy groups or associations and invite them to join WCPT. Discuss the feasibility of physiotherapist assistant training curriculum with authorities, National Physiotherapy Association, and non-governmental organizations. Since 1979, the ICRC is continuously increasing its support to rehabilitation services in low-income countries and will continue this in the foreseeable future. And we hope very much that this panel discussion will help the ICRC to move forward to its goal. Thank you very much.
Thank you. Then can we ask Amparo from Colombia?
Good afternoon. First of all, thanks to the Scientific Committee of the WCPT for the opportunity to stay in this panel and you by the attention. Excuse me by my English, but my language maternal is Spanish. Okay? My presentation will cover three principal topics. First, conditions for the access to physical therapy service in Colombia. Second, development action by stakeholders. And three, challenges for the profession. Colombia is an emerging country with multiple richnesses, ethnic, cultural, and geographical diversity, natural resources, and strategic geographical location in the Americas. However, we have many problems with the access to the physical therapy services, and particularly to the physical therapy due to different causes: the demographic and epidemiological context, the impact of the public policy, the condition related to professional offers and practice environments. Colombia has a population of 45 million people. The country has experienced the demographic and epidemiological changes, characteristics of transitional societies. We have problems typical of developed countries and problems typical of emerging economies. The aging population, the industrialization, and the changes of the lifestyle has led to an increase of the chronic non-transmissible diseases. In Colombia, 40% of the population is poor, and 2 million people lie in condition of extreme poverty. The communicable diseases are public health problems. Its intensification is related to growth of poverty and marginalized populations, the rural migration, the weakness of control programs, poor access to services, and limited education. The forced displacement from the rural to the urban areas due to armed conflicts is other problem. On the other hand, the neoliberal reforms that oriented the public policy and that were adopted in many countries of the region has impacted the access to health services. We had many barriers for the access due to insurance enrollment as a consequence of the lack of clear definitions of coverage and economic barriers due to high costs. Additionally, there are other problems related to income, education, and characteristics of service, such as geographic barriers and quality of care. Colombia has 40.3% PTs by 10,000 inhabitants. In relation to the offer of the professional and the practice environments, the public policies has generated negative effects on the supply and demand of health professionals, the quality of training processes, and the employment opportunities in the health sector, in particular for the PTs. This, of course, also affect the average pay and professional recognitions. With regards to the education market, Colombia has seen an increase in the supply of institutions, programs, and quotas. However, the country does not have policies to undertake a need analysis in order to regulate the supply of and demand for physical therapy professionals. Despite the increasing number of the professionals, there is an imbalance in the number of physical therapists working in urban and rural areas, leading to a lack of service provision outside of the majors and the medium cities. In relation with the developed actions, aware of these situations, in recent years, the universities have made an effort to transform the professional profile of physical therapists. In particular, the change of the curricula has increased new opportunities for the work of the physical therapists in the primary care and the teamwork with other professionals outside the health sector. Areas such as public health, sports, occupational health, social management, and social inclusion has been provide new opportunities for the professional development. To to the particular circumstances, the supply of the rehabilitation and the physical therapy services in Colombia have required innovative strategies, focuses on community-based rehabilitation, health promotion, and prevention of disability. Because the epidemiological transitions, the PTs began joining national public programs of health promotion and illness prevention, supporting community groups to create healthy life conditions. Initiatives such as the Healthy Communities Movement, using physical activity as a strategy of their competence, has been particularly helpful in this work. In our country, it's interesting the experience about the participation of the physical therapy in the will of the policy and resource capacity with local and regional health authorities for the advocacy of the disabled people's rights. On the other hand, the WCPT SR and the Colombian Physical Therapy Associations have started one communication with government agencies in order to strengthen the legal status for the profession and the creation of the professional school. In relation with the challenges for the professions, the educational institutions need to increase capacity at reform recruitment, teaching methods, and curricula in order to improve the quality and the social accountability of graduates. It's necessary to consult different actors about the number and skill levels for the physical therapists in order to define a standard for the professional practice according to country and regional needs and to increase social recognition for the PTs. And finally, to increase the participations of the PTs as a point to enter to the health care system and establish programs with primary health care providers. Thank you very much.
I would like first to thank the WCPT for giving this opportunity to share our experience and view with you. I would like to speak just briefly about the availability and accessibility of physiotherapy services for patients or people who need it in developing countries. First, there is limited literature and information about the use of physiotherapy services and healthy human resources planning in developing countries. So there is lack of evidence-based information, as Mike said before. So the information presented here has largely been drawn from government's reports and personal experiences where I work in UK, Jordan, Saudi Arabia, North Iraq, and Nepal. This information may also apply to some of developed countries. There is indicators that physiotherapy services are available in most developing countries. However, availability of these services does not mean it's accessible. It may be available, but it may not be accessible to those who need it. This could be because of the following reasons. First, the economic situation of these countries. Like, for example, in Jordan, we have 1,500 physiotherapists, but only 10% employed by government and private agencies. So this will encourage people to migrate from their countries to other countries where they can find job. Conflicts and crises in these countries, like wars, still exist in Middle East and many countries, where this increased demand for care and the resources will be directed to buy weapons rather than providing health services for people. Lack of a quality training program, including lack of training staff and therefore shortages of physiotherapists. I mean, many programs are starting in developing countries, but there is no accreditation process. There is no quality training program. So anyone, especially in the private sector, can start a physiotherapy school. Education system, like admission criteria, which is availability of good quality program and curriculum development. Still a problem in many developing countries. Health system, for example, some countries still fight contagious diseases. Like we visited countries, still they have fight polio and other children diseases, which for that reason demand for the basic health, and so physiotherapy services is not priority. When they have contagious diseases, they need to fight it first. And that's also the promotion from the WHO, where they set the priority for fighting the basic health needs more than rehabilitation. The amount and type of physiotherapy available in developing countries depends on where patients live, whether they live in big cities or in rural areas, their economic situation, and their health insurance status. Like they may have the physiotherapy just few meters from where they live, but they cannot offer to pay the services. And also there is lack of information and awareness about physiotherapy services among patients and among health professionals. We still many doctors who comes from many countries, not in Western countries, they have lack awareness about physiotherapy and the role of physiotherapy in many aspects. Also, we have cultural issues, for example, seeking help from traditional healers. We still have many people in developing countries go and seek help from non-professional and non-physiotherapists. Maybe because it's cheaper, maybe because they don't know about physiotherapy role for their condition. So that there is risk that without a global intervention by WCPT, and I think CPT should play important role to overcome these situations, and member organizations and other health and education agencies, these problems of providing physiotherapy quality services and shortages of physiotherapists will worsen, and demand for physiotherapy care will continue to grow. Therefore, we may focus our discussion on how to expand physiotherapy education and training, improving retention, and reducing geographical maldistribution within countries, inside some countries from rural to urban countries, and across countries between developed and developing countries. Thank you.
All right, thank you. We now have heard the panels set the stage and to give the status of physiotherapy worldwide. I will ask the members of the audience if you need to ask questions or clarity and comments, and we will answer from as best as we can from the panel. And please do feel free to come with some suggestions as well of how we can overcome some of these issues.
Hi,
You will do your name and country.
I'm Mark Goldstein from the United States. I want to thank all the panelists for the presentations, very enjoyable. But I have a question for Dr. Landry. I guess the state of the art for data collection right now is descriptive, and I don't think anybody has evaluated what the right number is that you've mentioned. So my question is, how would you even operationally define the right number of a ratio of PTs to population, or whatever you were specifically describing as the right number?
Okay, well, it's a good question, Mark. Thanks. A couple maybe thoughts on it. I certainly don't have all the answers because we're at such a status in the literature and the understanding. Now is the time to have the discussion and debate so we can create the data sets that will allow us to do our work and actually plan. But I would think a few things. One, at a macro level, we need to have a blunt perspective of a global human resource density that would be appropriate. For instance, moving down a level, in Canada, nurses have a number, and they've developed it through non-research means. That doesn't matter. There is a number of nursing staff that's required within a hospital department or within a ward. And they have done some very preliminary research on this, and they know that if you go below that health human resource number, people die. There's a direct and an immediate impact. Infection rates go up. So we need to have similar types of numbers at the macro level, and then within the meso and then micro. one of our challenges in PT is we often evaluate our outcome in less critical or less charismatic terms than death. Oftentimes it's quality of life, and quality of life gets measured over a period of time. So that works in our disadvantage from some level. And we need to start looking at things such as this, some of the data that looks at quality of life, and then link that with cost. Because until we have a good relationship with expending resources on developing resources, and that will save in the long term, we might be fighting an ongoing uphill battle. There are some strategies for it. The last point that I made earlier was, a PT is not a PT is not a PT. We also have to understand what's required for certain patient populations. So persons who have spinal cord injury. This is very complicated, I know. We're all clinicians here, but we need to understand, in general, a person who has a spinal cord injury at age 25 over the course of their life will require, within some parameters, some number of PT interventions. And from that we can work upwards to start thinking, first of all, how many PTs do we need, and how do they need to be trained? Now, spinal cord is not a good example because if you look over time, there's actually fewer and fewer people having spinal cord injuries, which is a good thing. They tend to have them now a lot earlier in life, so they live longer. But it is a small group of population. But things like arthritis, stroke, we know is about to become, is already and is about to become an even more global burden of disease. So those are some thoughts. But I'm hoping that from discussions like this, we can actually start creating templates for the type of data that we're going to need in order to start the planning process. It's a very long-winded question. I hope you have a follow-up for me, Mark.
No,
Hit me.
I did. Thank you for the. Then, and just quickly, then, if you can comment on the relationship between absolute numbers of therapists, the issue of potential overutilization, underutilization, and then what kinds of outcomes can be expected, and how that would all fit into a research agenda, so that if you had less therapists providing too many interventions, what is the relationship of that between a smaller number of therapists providing an appropriate number of interventions, getting similar or different outcomes, and how would this latter question fit into a human resources kind of agenda?
That's good, Mark. Those are tough ones. Maybe a couple commentaries. Whatever model that we end up building, and Mark Goldstein knows, part of my research agenda is actually creating a forecasting methodology where we can start plugging in numbers on the demand side and on the supply side, and then from the output is a gross measure of human resources into the future. So it's a predictive model. All predictive models are generally mostly wrong. There's huge error that is built into it, and it has to do with things like that, because in certain areas maybe funding actually drives utilization. If the spinal cord injury all of a sudden is primarily due to motor vehicle accidents, and if in a country or a region there's tort law, then all of a sudden there's a gaming effect of the resources. So we have to build in a little bit of a mush factor, a little slush in there. But it would be a better guess than what we currently have, which is shooting straight into the dark. So there's something from before and then after. In terms of a practical outcome, I think what needs to happen is, it may be WCPT or probably not. It's reliant upon our own member organizations. By the way, I don't think we should rely on WCPT to do all of this work. So in any case, I think it's important to understand, in every single country, what are the numbers for PTs? What are the retirement rates? What are the specialties? Where do they work in hospital, publicly funded hospitals, privately funding? It becomes a complex minimum data set. I haven't seen the minimum data sets for WCPT, but from what I gather, it might provide some numbers, but we're going to need a lot more specificity if we're going to use the data to start projecting and forecasting. Thanks, Mark.
Thank you, and we'll continue this in August, I suppose.
Yes, we will. Maybe this evening.
All right, we've got the next speaker.
Good afternoon. My name is Michael Steenbeck. I work for CBM, that is an international development organization supporting programs in developing countries. I'm personally very happy with the recommendation of WHO that there's a need to develop mid-level training and mid-level professionals in this field of rehabilitation. Something that I find very necessary also. The question now is, I think, would WCPT also embrace and promote that kind of measure? Because I think I've been observing that especially the established physiotherapists have kind of inhibited such a development because of, I think, protecting the physiotherapy profession. So that comes to the point that you put on the slide earlier on. Is this a threat to have PTAs or mid-level or not? I think it's highly needed. My second point is that looking at the world maps that you showed, it seems that there's a need for, or there would have been a need for this Congress as well as for the coming Congresses, that the audience in this room is going to change. Because now we have about 80% of this audience comes from the Western world, whereas the need is in the developing world. So I think that that is something that needs to be addressed, and we need to kind of facilitate that in the future we can empower national physiotherapists and related professions to be advocates and lobbyists within their own countries with their governments to ensure that education and service provision programs increase. And therefore I think there's a need for all organizations represented here to lower barriers for national physiotherapists in developing countries to become members of an association, a national physio association, or to set that up and to participate or to attend this kind of congresses, which means we need to subsidize that, because one of the barriers for national physiotherapists to attend here is financial. Thank you.
All right, thank you. I'll try and respond to some, and I would ask please the audience to give some interventions as well, and the panel members. You spoke about, firstly, would WCPT promote the training of mid-level workers? I do not have a straightforward answer to that, but because WCPT is made of member countries, the member countries, they are the first ones to put up their hands to say, my government would not support the training of mid-level workers. I made an example to say that in South Africa, the problem with mid-level workers is that the type that the government wants to train is a type that is not registrable with our board, our regulatory body. Therefore, we do not want it. We do not want to have a cadre of a mid-level worker that is not going to be regulated. It is a legal requirement that in order to practice as a health worker in South Africa, at least I think around the world, that you actually have to be licensed to practice. Therefore, in South Africa, no, we will not allow the mid-level worker to be trained. Is there a shortage of health workers in South Africa? Yes, there is a shortage. And we are saying, in the Africa region, Clito is here, and I think Tele is here, they can speak to that as well. We are saying that we do not promote the training of a lower cadre, rather promote the training of a fully fledged physiotherapist who is then going to ensure that there is supervision and support for the lower personnel. As well as we do not want to have the lower cadre, mid-level workers who are not going to be physiotherapists one day. The problem that has been experienced in Malawi, in Zimbabwe, is that you actually have your international organizations, for example, CBM, who come and train the locals for 2 weeks, for 3 months, for 6 months, and they become mid-level workers, CBR workers, and they are gone. And when they leave, nobody ever comes back to upgrade them to ever become a physiotherapist. So we are saying, no, we do not want that approach. We prefer an approach that if you start a program that they are going to be mid-level workers, they're going to be assistants, they're going to be CBR workers, there has to be laddering such that they can be professionals one day. We do not want people who are going to be mid-level workers until they die. It has to be out of a choice, not to be programmed in such a way that that's where you start and stop. We don't want a ceiling that is put up front to a program. We want it to have mobility and upward mobility, that they will study to go right up to the end. Am I representing Zambia properly, Clito? Yes, you want to come and talk to Zambia?
Just a little something over that. Indeed, in Zambia as well, we will not accept middle-level workers or physiotherapy assistants, as it is called in other areas, but rather we would want to see a fully-fledged physiotherapist trained to provide the service, because right now we are grappling even to employ the ones that have been, trained. There are plenty of them that have been trained and are not finding employment anywhere. So maybe one little thing that we could do is to network with those that are doing rehabilitation in some areas, so that we can actually export and use physiotherapists that are qualified as opposed to training mid-level workers. I think that is maybe the way to go. And also it will be a variance between, WCPT is saying we are going to train at a doctorate level, and then we grace down to assistants. I think it's a variance there. We need to train, we need to upgrade and go up and up and up.
I just want to interrupt because I think you'd like to have a rebuttal on your question, but can I just ask, South Africa and Zambia, if you look at this graph, does this change your mind or does this help in any way? Because our data seems to suggest when there's more health human resources, you have lower rates of disability. In Zambia and South Africa have some of the highest rates of disability globally. And so we know there's some sort of relationship between density of provider and the presence of disability. And I'm pushing a little bit because this is supposed to be a debate. So given we have actual empirical data suggesting that it is important to have higher volumes, are you still maintaining that it's not worth it to have a mid-level worker? And also given that the World Health Organization has fully sponsored the idea of community-based rehabilitation, which depends on community workers?
Dele?
I'm Dele from South Africa, from part of the developing world. I believe this data is true. There's need for help. However, it shouldn't just be any help. It shouldn't be help dictated by someone else who may not quite appreciate the challenges within the environment. I was going to make 2 comments and pose a question. And one of my comments really was to the fact that truly we need in African countries, the demand is much higher than the supply. But what type of supply should we therefore ask for? Any type of supply or quality supply? I don't think it's a supply that will offer the people anything that is different from what will be offered by physical therapies in any other country, also in the Western world. It's cheaper for our governments to train middle-level workers. Go to many of the African countries. the government will embrace. I was glad to listen to the Red Cross. You represent the Red Cross, yeah. I was happy to listen to you because I think I heard from what you said the need for collaboration. So it's not a question of the Red Cross coming into any of the African countries to say, hey, you have a need, we train this for you. But sitting with the local people to say, okay, what can we put in place to meet the demand? It will be very helpful that the African countries should be assisted in training qualified physical therapists. You know, when I saw one of your, I think it's the slide before this, a paper in a manuscript in preparation, you know, it encouraged me. There's something else, something similar, but relating to physical therapy education in Africa that I've been working on for a period of time, you know, and sometimes you lose the interest, you come back to it. I think just listening to you makes me now to want to complete it. There is a dire need for healthcare workers. But let's ensure that we do have quality. Population of Africa is about over 1 billion. How many physiotherapists do we have? Just about 5,000. So you can see, therefore, that the demand and the supply, they are just not speaking to one another. If I can pose my question, our medical colleagues went through this process many years ago in which they could now say, hey, for this number of the population, you need X number of medical practitioners. And they've gone through that. While they were going through that, they never thought of us as physical therapists. They never thought about audiologists and all the rest. Now that we are going through this process, should we not maybe pay attention to the other rehab needs, like audiologists, occupational therapists, who are fewer in number compared to physical therapists? Should we not therefore be dialoguing with them to say, maybe our training structure would be affected? I'm not sure. But just to get them on board so that we do not, again, make the errors our medical colleagues made in believing that the doctor has the solution to everything. So also, the physical therapist does not have the solution to all rehabilitation needs.
All right. All right, thank you, Dele. We don't want to get lost in the debate. We want to finalize the first point of the mid-level workers, and then we can come to the audiologists. We really don't want to impose ourselves on the audiologists, I would imagine, but we want to finish the mid-level workers. Barbara, you want to talk to mid-level workers?
I really appreciate your interventions, and I can understand the need of the volume and the need of deciding which type of training you want. But this morning we were lucky to go to a networking session about physiotherapy assistants, and there were representatives of Canada and United States of America and also the UK. And I was quite relieved to see that if the system is well organized, everybody can have his place, and it should be well described who does what, and if there is a need of physiotherapy or a need of caring for the people. It can be in remote areas in Canada, for example. It can be in remote areas in Afghanistan. Then we need to respond to that need. And of course, it's essential to treat physiotherapists in each country. But if this is not possible, should we not maybe train other people who can do part of the job in relation with physiotherapists?
All right. Whilst you're coming to the mic, I do want to say that if we're training physiotherapy assistant, who are they assisting if the people they are meant to be assisting are not there? That's the trouble we're having here, that we want to train people to assist, but the people that's meant to assist are not available. So we need to think about that as well.
Thank you. My name is Mary Martin. I've worked a long time in Nepal. I'm from Canada. I guess two things. I hear two different things with respect to the mid-level issue. One is talking about physio assistants, and the other is talking about CBR workers who would be trained in a little bit of physio, OT, audiology, whatever. And I think it would be important in the debate to differentiate between those two. I think someone mentioned a career ladder, and I agree that that's really important. And if you stick within the physio profession and have a physio assistant who potentially then could go on and study to be a physio if they wanted to. I think that's a very different question from the one of should we be training generic rehab workers. And I think it's important to differentiate. I mean, personally, and from what I've seen in Nepal, I think to go through physio as a profession is probably the wiser route, although I believe that CBR is a tremendous need in Nepal, and I think physios have a real obligation to learn how to support CBR workers. I don't see a career ladder from a CBR worker up to a physio, because I think it's a different, it's a different kind of profession. So I think within physio, to have physio assistants, if there are physios from whom they can be assisting, I think the physios need to come first. That's why we trained in Nepal physios before we wanted to look at physio assistants. The other issue is the jobs versus the need, and I think that in Nepal and in many other countries, I'm hearing about countries that have physios to export because they're unemployed. I think there's a question of, are they unemployed because there is genuinely no need for physio, or are they unemployed because the advocacy and the policy making that needs to happen at the government level has not been able to happen effectively? I know that Kanchan mentioned that in Nepal there will be physios potentially unemployed. There already are, and yet we have a tiny, tiny percentage of our population being able to be serviced by physio, and it's because in the last 10 years the government has created 3 physiotherapy posts in the last 10 years. And so I think that WCPT has a role to play in helping the developing countries to advocate with their governments, equipping the national organizations to advocate effectively with their governments to have more funding for physio staff in the public sector. Thank you.
Just to maybe give another piece of information, Ireland, is it a developing or developed country? Ireland? Developed. They've got an oversupply of physiotherapists as well. They do. They've trained physiotherapists. They don't have jobs also. Exactly.
But let's be honest, I mean, the massive austerity measures that have occurred, sweeping Europe, not seen in generations, is the cause of that. So it comes to, I think, maybe Mary or somebody else, you know, what is the purpose of the oversupply? And that such a scenario is very different than what we just kind of what we talked about in. But the other thing that you have to be cautious of, and a lot of the health human resource literature suggests this, especially the nursing workforce, is it goes in rhythms. They go in rhythms of oversupply and then undersupply, and it's up and it's down. You know, we are not even in that game because we're not even sure, you know, what the numbers are. Somebody else, I think we talked about, maybe it was Mary, around developing countries and, you know, what they need. Most of there are still a lot of countries who are not members of the WCPT. And so to suggest that WCPT represents all of the so-called developing countries, we're not quite there. And even among the countries who are members of us, the data is scant. And we've emailed, it's just hard to get the data. But without the baseline, it's hard to know where this really should be.
Did you want to say something first?
Okay. I like to complement the situation to spot the mic. I think every country have different needs to the formation of the professional in the physical therapy. I think the WCPT have the opportunity to establish standards for the general practice. Despite this situation, every country have the responsibility to establish what are the needs of the populations, what are the determinants of the health, of the disability of the populations. In this order, it's necessary identify what is the answer of the physical therapy according to the real needs of every country. I think it's difficult to establish, for example, Africa have the needs of the assistant physical therapy or professional physical therapy. No, every country have the opportunity to identify what are the profile of the professional, what answers the need of the populations, what are the public regulation for the standard of the professionals. It's necessary establish one dialogue into providers, governmental agencies, universities, and the other sector in order to establish the competence, skills, and levels with every country needs to answer to the responsibility social.
Don't know, can you hear me okay? My name is Moni Frick. I'm from Winnipeg, Canada, in the center of Canada. I think I usually play the diplomatic game and just look for is there a middle ground? So where there are physiotherapists, can you have some sort of hybrid model of community-based rehab program with a physiotherapist, in our case, supervising? So I started a rehab program in the Central Arctic in Northern Canada through the University of Manitoba. We were very fortunate that in the province of Manitoba we have a wonderful data set. I worked on my master's degree with the data set. There is one publicly funded physiotherapist full-time for every 5,000 people in the province of Manitoba. Don't have a lot of statistical mathematical formulas. So when we started the program up in the Arctic, we looked where the morbidity and mortality rates and the disability rates are at least double what they are for the rest of Canada. So if we started off with 1 per 5,000 people in the province of Manitoba with a 10% disability rate, and if the disability rates are twice as much, I threw that number out to government that we should have twice the number of physiotherapists as we do in Manitoba, up in the Kavalik region of the Central Arctic, and we were fortunate enough that we got it. So we had 2 physiotherapists full-time for less than 10,000 people up in the Central Arctic. But one of the goals of the program was to do something in the communities. The Central Arctic in Canada is spread out very far. You can go by dog team between some of these communities over the course of several weeks, but it's not very feasible for the physiotherapist to do that. We had the physiotherapist based up in the Arctic, but we needed something community-based. Certainly I looked at the literature around CBR, but that wasn't going to work in our country. No one was going to volunteer, if that's really the essence of CBR, that you're volunteering in your community to promote the issues around disability. When I did the needs assessment to start the rehab program, I went onto the radio and I tried to do community meetings. And certainly there was a very clear message that people wanted local employment if there was going to be rehabilitation services. We also started OT, SLP, and audiology. It was done on an itinerant basis. But there was very little uptake for people wanting to move from the Arctic and abandon their families and their cultural way of life to go down south to actually leave for 3 to 4 years to do a university degree. And now that the physiotherapy program in Canada is a master's degree, now we're looking at 5 years. So for them, having a rehab assistant program worked better. That was the message that I got from people locally. So what you're saying from Colombia, that every country has to assess their own needs and develop programs for what's happening locally, I think is very appropriate. So there has been now a rehabilitation assistant program developed in the Arctic. Unfortunately, the attrition rate was very high, but there are now community-based workers who work for all 4 disciplines in rehab in each community. It's not the answer. We have no Inuit physiotherapists in all of Canada. That is certainly our goal. I'm also chair of admissions at our university, and we do everything we can to try to recruit Aboriginal students into our programs, but it's a matter of leaving their neighborhoods, their families, their children. That's not necessarily going to work for this particular population. So we try everything to try and get a representative population of physiotherapists in the country. But short of that, to strive to that, is there not some merit in having community-based workers, this middle-level worker, to at least model what rehab is able to offer, perhaps going into the high schools, working with the children, so that the children can understand what we have to offer. Perhaps there'll be 1 or 2 individuals who'd be willing to move out of their community to get the education so that they can bring it home again and actually then have, in my case, Indigenous healthcare providers, Indigenous physiotherapists. So is there a hybrid? Can we come up with a model that works, that needs to be developed, I suppose, in every region, in every country for itself?
All right. Shall we ask
the question was who supervises the CBR workers who are not technically CBR because they're employees of the government of Nunavut. It actually is the physiotherapists, the occupational therapists, and the SLP who go into the communities every 4 to 6 weeks. And otherwise, well, we have the luxury of using telemedicine, telehealth, telephone, or video conferencing. But we're lucky we have that kind of technology available.
All right. I don't think I'm going to have all the answers. I mean, I think I'll take the whole day if I were to answer. Yes, CPR in some countries there is. Zambia have, much as I have said that they don't want physiotherapy assistance, they've got CPR workers that they actually have modeled according to their own needs. What they don't want is a program that is flown in, shipped in. They don't want the shipping in. Shall we request the delegate standing to talk?
I'm Phil Tygell from the United States, and of course very spoiled in the way I get to practice physical therapy, and this is all very eye-opening. And I'm curious to hear from people about how they envision physical therapy needs to be practiced in their areas. And you've kind of alluded to this, but I'd actually like to hear it from people who are in the areas. You know, I'm very spoiled. I get the opportunity I can only supervise maybe 2 or 3 people who can work under me. And I get to see my patients 2 or even 3 times a week. And I don't have to do anything more than orthopedics because there are other people in the community who can provide pediatrics, geriatrics, neurology. So I see this very small world. How do you picture the role of the physical therapist in actually treating patients in some of these areas where there's this tremendous need, and for the next 20 years, 30 years, we're never going to have enough physical therapists? How often do you envision the physical therapist seeing the patient? How much hands-on care do you see the physical therapist in those communities doing, and how do you see the physical therapist's role in teaching, supervising, I don't know what if you want to call them mid-level workers? How many do you see them in your area of physical therapists being able to supervise to begin to meet the needs of as many people as possible? I'm just fascinated by the different pictures that you all can paint.
Barbara, you want to talk to that? And then Amparo?
It's good, I lost the track. I just wanted to come back to the point you were saying about Canada North, and I think there's other subject about migration, because yeah, it's a good idea to bring the people to get physiotherapists, but then you have to be sure that they go back to where they come from, to their communities. And our experience sometimes, problem is that yes, you sponsor them for 3 years to do a bachelor degree, but then are they going really to go to the rural areas where the needs are? So the question of migration, Mike is also examining. It's not only from developing country, but it's also from developed to developing countries. It's an important point. Yeah, about the needs of physiotherapists in the place where we are working, it's really what I learned the most is that the patient load even is quite different. The patients are different, and for example, a person with amputation can be rehabilitated or re-educated in 1 or 2 or 3 days, or a spinal cord injured patient can be independent in like 2 or 3 weeks, because there is not the possibility to train the people for 3 or 4 months. So for sure, the education of the person who is training these patients will be also different. Doesn't mean it has to be less, but it's a completely different setting, and the outcomes are different. Did I answer? Not.
I think we have traditional need that the physical therapy have the responsibility, the answers. But I think the future for the professions is in to renovate the capacity to establish one dialogue with other sectors. I think the need to improve the competence scale of the physical therapy with work with other disciplines, other sectors, in order to establish the cooperations of the Association for New Opportunities. For example, in the global health, in the situations, for example, new opportunities for intent, the poverty, and other determinants, is necessary that the professionals to intend the public policies, economical situations, determinants of disability in other situations. Is necessary to improve the participations in public policy in general. For example, in Colombia, we have the experience in the participation with the governmental agencies to design and to implement public policies in public health, particularly in programs and plans of the physical activity, tobacco laws, obesity, in order to combat the sedentarism and other problems. Currently, I think it's necessary to establish one dialogue with the policymaker to strengthen the association into professional and the delineate and the elaborate plans and programs with the community in order to establish answer real to the populations. The population have need every day is transformed. It's impossible to think one physical therapy with a particular idea about the design of the competence for the physical therapies. It's necessary a change according to the needs of the new century. In the present, the strategy is a physical therapist competence for answer different needs of the population.
Can I just make an added point? Just to give you some figures I just made up. About 80% of persons with disability in the world live in so-called developing countries or low-income countries. Among them, 2% have access, some access to rehabilitation, full stop, period. So the painting of this picture is so massive, and I'll just be completely blunt. If we don't start making a move to do better, I'm not sure if we know exactly where we want to go. I don't know if we need to really go and discuss sort of the higher order, training requirements. We can start making some movements right now by training extenders, but having control over what those extenders do. And by doing so, we can cast the net much wider than it is. Just to clarify something, I think somebody said before that WCPT supports the notion of a DPT around the world. I'm not sure if somebody said that, but that would be incorrect. That would be completely incorrect. So, and I've been to many, I've sort of worked for a few years myself elsewhere, and it truly bothers me in certain countries where the focus of education is to shift towards a DPT, while massive and growing issues around disability are happening in their communities. It is time to get practical and take ownership of our profession, because if we don't, somebody else will. So I completely agree with what you said, Amparo. We need to have that dialogue, but we need to get off of the theoretical constructs here and start getting practical about how we are going to address this slide. Sorry.
Can I just do a practical thing? We're supposed to finish at 3:15. And according to my watch, it is 16 minutes past 3. And according to the debates, we still want to wrap up some of the points. They're very interesting. So I would need to be advised by yourselves whether we continue or we continue with the debates outside, as some of us have to go and attend other things. Yeah. Now, I would have loved to wrap up the points, but I see Brenda Myers is sitting at the back, and we've picked up some points, and Mike has been writing some points. So we would actually be able to continue these discussions and make sure that people understand where we come from. And data collection is happening. We need to train some level of cadre but it has to be controlled. We don't want the helicopter approach where it comes and drops on us. And we are grateful to all of you to have come and participated in this very important issue. Thank you very much. This is the end of the session.
If you're interested, I have some pamphlets for the international summit that's going to be held next fall.